Good morning, good afternoon. My name is Michel Shamy. I am a neurologist in Ottawa, Ontario, Canada, and it's my pleasure to present to you today some of the work that my team and I have been doing related to the justification of randomized trials using the example of the hydroxychloroquine trials for COVID-19. As I alluded to, this work is not mine alone. It could not have been done without the support of Brian Dewar, my research associate, Mark Fedek, a PhD philosopher, and Vignan Yogendrekumar, who was a research fellow with us at the time. This particular work has no relationship to industry, but I've been fortunate to have funding from a number of organizations over the course of the last few years that have contributed to what I'm presenting today. In case we get cut off or you have to leave, here's our last slide first. Randomization should be ethically justified, and this ethical justification, at least in part, relates to an assessment of uncertainty. Unpacking justification may help to further clarify the relevant sources of knowledge and thresholds for permissibility and necessity of any given trial. The example of the trials of hydroxychloroquine for COVID-19 demonstrates how challenging this process can be and that we're generally doing a bad job of it. Just to give you a little bit of background and perspective, so I am not a philosopher, I'm not an epidemiologist, I'm just a stroke doctor, but I became interested in this question of the justification of trials back in 2012-2013 when I was a fellow at the Calgary Stroke Program. And essentially, the stroke world was being rent asunder by disagreement about whether a particular trial was ethical or not. And the circumstances were such that there was a trial surrounding a treatment, endovascular thrombectomy, that was being used as standard of care, that we largely believed was effective, but that had no randomized trial level evidence of efficacy to support it, and in fact had been investigated in 3 previous randomized trials that had suggested no benefit. And so the question was another trial warranted? Some argued yes, some argued very strongly no. And so these experiences framed my interest in this question of when do we really need an RCT, and inspired me to look into the question of hydroxychloroquine. To bring you up to speed on some of the work that we've done in the past, and I presented on this at this conference last year, essentially I think we all agree that randomized trials are very important and can be very helpful to determine the relative efficacy of treatments, but at the same time, randomized trials should be justified, and that is because obviously they are costly, they are difficult to administer, they can be difficult to interpret, but probably most importantly, the fact that they present an ethical risk. Physicians have a fiduciary duty to their patients to offer the best possible care, or at least care that is possibly the best, and randomization may impair the physician's ability to honor that responsibility if it entails randomizing patients away from a treatment that is known to be effective. And so this process of ethically justifying a trial has something to do with certainty and uncertainty. If we are already certain about the outcome, that one treatment is better than the other, then randomization is unethical. So we need to have some way of establishing whether there is uncertainty around a particular question. And unfortunately, this is actually quite complicated and perhaps more complicated than it is given, than the attention that is given to it. Obviously, there are other ways in which a trial can be unethical. For example, if consent is violated or patient privacy is violated, etc. And I'm not going to talk about those issues today. With regards to this question of uncertainty, you probably will have come across the term or the concept of equipoise. So the word equipoise is commonly used as shorthand to refer to some state of uncertainty surrounding which treatment is superior and is used to provide an ethical justification for randomization. Now, despite its ubiquity, equipoise has been widely criticized for a number of reasons. And one of those reasons is nobody really knows what it means. So we recently completed a series of interviews with 45 stakeholders, trialists, research ethics board chairs, philosophers, and bioethicists And they gave us 7 different definitions of equipoise, 7 different operationalizations of equipoise, and some didn't even know what the term meant / had never heard of it. So we've argued that let's put equipoise aside and turn to a methodology that we are comfortable with, notably the systematic review, as the way to assess in a fair and transparent manner at least whether there is uncertainty about the question being posed in a particular clinical trial. Now, when it comes to this concept of justification, I think that we can break that down a little bit more into 2 concepts, permissibility and necessity. So this is new work that adapts some concepts we've introduced in our prior writings. In 2017, we introduced 3 questions that we felt were essential to determining whether a trial was ethically justified. Has the question already been answered? Are patients likely to be harmed by participation, meaning are they being deprived of standard of care or treated poorly otherwise? And then is the study of sufficient methodological quality that it is likely to make a meaningful contribution to the literature? In retrospect, when we were asking those questions, we'd like to conceive of those as questions of permissibility. Would it be okay? Would it be permissible to do that trial? But what it leaves unanswered is the question of necessity. Do we really need to do that trial? And so I think we need to ask those questions differently, right? What is the expected value? Is this trial really going to change practice? And so I have for you here a table from the seminal paper by Ezekiel Emanuel from 2000, JAMA, about how to think about the ethical justification of trials. And I think our questions kind of collapse some of the features that are introduced in that paper. Notably, first, what is the necessity? What is the scientific and social value proposed by this trial? And then, if it is necessary, is it permissible? I would like you to keep those concepts in the back of your mind as we now turn to a different set of concepts, and this is work that we introduced last year in the Journal of Clinical Epidemiology. That when thinking about the uncertainty around a given trial, it may be helpful to think about the different kinds of trials that are done. And I don't mean pragmatic versus cluster, etc., but rather the type of comparison that is being wrought in the study. And so we thought about the fact that we could put all trials into 4 categories. We called them 4 quadrants. And yes, that is totally inspired by Star Trek Deep Space Nine. So in the alpha quadrant, we have trials in which you are comparing one standard treatment to another standard treatment. For example, to figure out which of 2 blood pressure medications is more effective. In the beta quadrant, we have a circumstance where comparing a novel treatment to a standard treatment. So this might be an example where you have a standard for cancer of 3 different chemotherapies, and now you're comparing that to a novel regimen. In the gamma quadrant, we have standard treatment now being compared to placebo. So this is where you have a treatment that is generally done, but maybe has a poor level of evidence, and so you are randomizing it against the lack of that treatment. And then lastly, you have the delta quadrant, in which you have a novel treatment versus placebo. So your standard is actually placebo. There is no accepted treatment in this for this condition, and you are trialing a novel treatment. And what I would like you to think about is that in each of these quadrants, our thresholds for permissibility and necessity are different. And this is how we present it here. So in the alpha quadrant, where you have standard treatment versus standard treatment, the permissibility threshold is low, right? It is generally, you can imagine that if you've got a good amount of evidence available to you that both of these treatments are relatively good, that it is very unlikely that you're going to harm patients. You are not depriving them of standard treatment by giving them one of those 2. However, the necessity threshold is high. So we've got 2 good treatments already. Why is it really necessary to prove that one is a little bit better than the other? So in alpha quadrant, low permissibility threshold, high necessity threshold. In the beta quadrant, where we've got a standard treatment versus a novel treatment, the permissibility threshold is a little bit higher than you'd expect in the alpha quadrant, right? You already have a standard treatment, and so you would want to establish through preclinical data and mechanistic reasoning that there is a reason to presume that there is uncertainty and that the novel treatment might be better. Similarly, the necessity threshold is going to be lower than in a situation where you're comparing two standard treatments based on clinical and paraclinical realities. Maybe this new combination has the potential to be more tolerable to patients, or maybe is cheaper, and may also have the strength of mechanistic reasoning and preclinical data to suggest that it is as good, if not better. In our third quadrant, in the gamma quadrant, you have a situation where you have a standard treatment that you are withholding because it's never been tested, and maybe you have reason to presume that it's not actually necessary in all cases. Now, in this setting, I would argue that the permissibility threshold is high, and you would need to have quite strong data from a systematic review to conclude that this trial could go forward. And you also need to have very high necessity threshold to say that it should go forward, right? To really be convinced that there is a great social value to be expected by randomizing patients away from a treatment that has been considered standard practice for some period of time. Lastly, in the delta quadrant, you have a placebo treatment as your standard because there is no treatment for this condition, something like, for example, intracerebral hemorrhage. Low permissibility threshold, low necessity threshold, because by definition, there would be great value if you were to determine that any treatment is better than nothing. Now let's move on to think about the example of hydroxychloroquine for COVID-19. So hydroxychloroquine is an anti-inflammatory and anti-malarial drug that has been around for a long time. And in the early days of the pandemic, preclinical evidence suggested that hydroxychloroquine could be effective against COVID-19. Trump and team advocated for its use, and so many RCTs were launched into this condition. And we sought to map the landscape with an eye towards these questions of justification. What did we find? We found that over 200 different randomized trials of hydroxychloroquine for COVID-19 had been launched, and that as of November 2020, 135 were ongoing, 46 had been closed, and a number were still in the registration planning phase but had not yet been launched. There was significant overlap. There were 96 different trials of hydroxychloroquine for active disease, 39 for prevention. 58 were randomizing hydroxychloroquine versus placebo. 120 were randomizing hydroxychloroquine versus another drug. 45 were using hydroxychloroquine as the so-called standard of care against which another drug was being compared. There were 29 trials of hydroxychloroquine among healthcare workers, 50 trials among inpatients, admitted patients, and 56 for outpatients. So how do we interpret these findings? Essentially, there were many randomized trials of hydroxychloroquine, many of which were likely redundant, unnecessary, and impermissible. So when a question has already been answered, further RCTs are unethical and wasteful and potentially harmful. And I don't have time to go through all of the history of this, but in early June 2020, the results of those first randomized trials became available that essentially hydroxychloroquine was ineffective and potentially harmful. The research community responded very quickly to political interest in hydroxychloroquine, launching dozens of trials within a few weeks of former President Trump's announcement of interest in hydroxychloroquine. But the research community was also very slow in responding to accumulating evidence that it was ineffective. Now, this is to acknowledge the fact that it is difficult, methodologically and philosophically, to establish when a trial should be suspended. But there are ways to address this problem, and one of them, as we heard from my co-keynote speaker last year, Alex Sutton, is maybe this question about the stability of systematic reviews. that might be your answer of when it is appropriate to suspend or stop an ongoing trial. I think the case of hydroxychloroquine also further demonstrates the weakness of the concept of equipoise. Essentially, at the beginning, when trials were being conducted, equipoise, by which we mean some summary of physician opinion, is essentially useless because there's no basis for any opinion because there is no evidence to support any opinion. And then once there was evidence, once there were data, then opinion again became irrelevant because we had evidence. Now, what quadrant would you put hydroxychloroquine trials into for thinking about our concept of the 4 quadrants and permissibility and necessity? In March 2020, you have a new disease of COVID-19. You have no effective treatments. I would say that a trial of hydroxychloroquine in that setting would be in the delta quadrant, would be under low thresholds for permissibility and necessity. That's right. But soon thereafter, the FDA granted hydroxychloroquine emergency status as a standard care treatment. Now trials would fall into the beta quadrant, I guess, where you're comparing a standard therapy to a novel therapy. And therefore your thresholds for permissibility and necessity change. Within a few weeks, again, the FDA rescinds its emergency status and declares hydroxychloroquine ineffective. So what quadrant does the trial fall into now? Well, they're in the presence of large bodies of evidence for and against hydroxychloroquine and other treatments, with that evidence saying that hydroxychloroquine is ineffective, really it doesn't fall anywhere within the quadrants because all of the quadrants presume that there is existing uncertainty. So what lessons can we draw from the hydroxychloroquine affair? Essentially, redundant, wasteful, and unethical RCTs were common, and they might be avoided, I would argue, if RCT oversight were better organized. For example, if there were centralized registration, review, and dissemination of results. If we had a more robust ethical framework to assess when trials are permissible and necessary, maybe that is the 4 quadrants idea that I've proposed here. And that RCT results should be made public as soon as possible to inform ongoing trial oversight. Thinking more deeply about how a particular research ethics board or organization should handle these challenges, I would argue that they should consider not just what is known, but what is likely to be known. So if you have already reviewed and approved 20 trials of hydroxychloroquine, maybe the 21st trial should not be approved until we already have evidence from the ones that are active. I would also argue that REBs would be greatly aided by the presence of kind of real-time or live systematic review technology, the kind that developed over the course of the pandemic. And recognizing that this is a very difficult thing to do to respond to real-time accumulation of evidence, especially in the pandemic, the field was moving so quickly. So for example, there's an American group led by Michel who wrote an article published in the American Journal of Medicine that was submitted in spring 2020, arguing why hydroxychloroquine might be effective, giving a pharmacological rationale. That was published online in August 2020, already after the trials of hydroxychloroquine had demonstrated the lack of efficacy, but it wasn't published in paper until January 2021, presenting a mechanistic argument for a trial that for a treatment that we had known was ineffective for over 6 months. Just to return to our takeaways, randomization should be ethically justified, and this ethical justification, at least in part, relates to uncertainty. Unpacking this process of justification into concepts of permissibility and necessity may help us to work through the process. And if anything, we really do need help. The example of the hydroxychloroquine trials demonstrates how challenging this process can be and continues to be. Thank you to the conference organizers, to the audience, to my research team, to the frontline healthcare workers keeping us all safe, to the patients who make clinical research possible, and to my family for their ongoing support. Thank you.